Okay, so I apologize. Today we're going to talk about anterior vertebral tethering. The title of this was a potential growth preserving surgical option for select spina bifida patients with progressive scoliosis. And I guess the bad news would be that we're not specifically talking about spina bifida, but I would like to target that as a potential area that tethering could benefit. What I'd like to do is spend a bit of time talking about, we've really been at this tethering technology for more than 20 years. And I'd like to give you some idea of the basics and the principles that we've used to take this really from an idea on a napkin to patients. And that's really going to be only possible if I tell you a little bit about how we think about scoliosis, as spinal deformity surgeons, and the challenges we've had to work through to get this to even work in a more straightforward type of scoliosis, just adolescent idiopathic scoliosis. So with that, I'll get started. These are my disclosures. I'm a consultant to the FDA for tethering, and I do receive royalties from Zimmer, but not for tether. This is the device that we're talking about. Just a simplified, 2 screws and what the cord looks like. For 10 years, we used this off-label because it wasn't approved. And as you mentioned in the introduction, we now have approval for a device system called the Tether. So what are the goals of tethering? Well, this is an adolescent idiopathic scoliosis, and the curve's getting pretty big. 40 degrees is about the threshold where you start thinking about surgery, and 60 is almost getting too big for tethering. But the goals are really initial correction of the curve, and this we got more than 50%, and then subsequent control of the curve over time. And that really hints at getting additional correction by harnessing growth. And there are additional goals. You want to keep the spine flexible, preserve growth, motion, and function, maintain the health of the spine forever if you can, reduce the risk of adjacent segment problems, and maybe even do something minimally invasively. Those are really good goals. I guess the question today is, can you achieve those goals, or a substantial number of them in spina bifida? And I want you to remember this case because we're going to talk about it at the end of today, but this is a pretty challenging spina bifida patient with a 79-degree thoracic curve. That's the bigger curve in the driver. The 55-degree curve below is substantial, but isn't just a curve, it's kind of collapsed. And what you see is a significant trunk shift. That dot is the center of T12. It's way off, several inches off to the right. That's not the only problem. The entire thorax has collapsed down onto the pelvis. And if you can see these marks, these white marks, you can see the bottom of the rib cage is actually below the top of the pelvis. That crowds the abdomen, the abdominal contents push up the diaphragm, then you don't have as much volume for your lungs. And, untreated, this is very problematic. So a lot of challenges for even a more typical spina bifida patient. So what I want to do is take you through the target we set years ago was idiopathic scoliosis in adolescence. They were, larger patients with better bone quality. Their problem of scoliosis occurred when they could tolerate surgeries pretty well, and for the most part tended to have just one issue, and that was the curve. So it was a less complex situation. And if you're going to try anything new, it's sometimes a good idea to try it in as clean an environment, as simple a situation as possible, so you can demonstrate proof of concept. Anyway, adolescent idiopathic scoliosis is a 3-dimensional spinal deformity, similar to the scoliosis you see in spina bifida in some ways. It affects 2 to 4% of all populations and represents almost 90% of all scoliosis. So it's a pretty big center of the target. We're trying to prevent this curve, which is a mild curve, from getting to this curve, a much more significant undertaking. We have been challenged for years in all of scoliosis treatment, doesn't matter what type, by a limited number of treatment options. And I've listed 3, but observation isn't even really a treatment option. It's not unreasonable for smaller curves that are not going to progress or show low risk of progression. Bracing is better for curves that are in the moderate range, and surgery for curves that really pass the 40-degree mark and are in a surgical range. Now, the one problem with that surgical category is really for 50 years that has meant one thing, and that's fusion surgery. And I don't think fusion surgery is a bad option. It just has limitations, and it's really best categorized as a salvage treatment. So it eliminates growth, motion, and function of the spine, really changes your spine where you do the fusion from a flexible structure to something that's more like a femur. So it's a profoundly non-physiologic treatment. But even having said that, that probably was the only treatment for this patient with a 113-degree curve. So it's a pretty big undertaking, and that's reasonable if you have a really malignant type of curve. That curve I just showed you was one of the bigger curves we've treated, or I've treated in my career. And this is one of the smaller curves, 43 degrees. And in a growing patient, 43 is going to get to 50 or 60 if you leave it. So this is a nice fusion to, almost eliminate the curve, balance the spine in multiple planes. But that is a very long, rigid segment of the spine that doesn't move anymore. And, early on that can cause some issues, but later on, it can cause premature wear and tear of the adjacent segments. And I tell people this all the time, is all those nice things about doing tethering, or the early benefits, are not the reason we started this. We were very interested in this, avoiding this adjacent segment problem long-term. So the best analogy I can give for fusion is that it's very much like boarding up a window in your house. If you had a broken window in your house, you wouldn't board it up. You'd put another window in there to restore its function. But if you didn't have a window, you might have to do something like put a board over it so the rain and sleet didn't come in. The problem is if you wind up having to board up all the windows in your house, you essentially live in a cave, which is not a great option. This was the patient that really got us started thinking very seriously about alternatives to fusion. This patient had a fusion that did well for 30 years. A very famous scoliosis surgeon took care of this patient, did a great surgery, and it lasted for 30 years. And then they developed an adjacent segment problem, which then broke down. The disc below broke down, and she had an additional surgery. And the long story short is she had 40-something surgeries over a 20-year period. So that's sort of mind-boggling. She did well and would have been considered cured or a success, and then really had a dramatic, maybe even catastrophic outcome with multiple surgeries that left her fused all the way down to her sacrum. And you would think the story was over at that point, because her whole spine was fused, but she disassociated her spine from her pelvis and she had an unstable pelvis. There were several attempts to fuse that, and they didn't really work. So really nice lady, did well for a number of years with a very straightforward scoliosis surgery, and then really wound up in a very bad place, probably because of the profoundly altered biomechanics of that fusion treatment. So alternatives to fusion have been sought for many years. You can limit the fusion, do a shorter fusion or just fuse half the spine on one side. A hemiepiphysiodesis doesn't really work very well. There are other goals where you delay fusion using traditional growing rods or even magic rods, things that allow you to grow, sometimes involve multiple procedures, or even a Vector. Those delay the fusion because for the most part, you wind up fusing those patients long-term. What we're talking about with tethering is really avoiding fusion altogether. So we call that fusionless scoliosis surgery. It sort of began with stapling years ago, and really is now called tethering. I define fusionless scoliosis surgery as a single, minimally invasive anterior intervention that achieves scoliosis correction without fusion, and thus preserves growth, motion, and function of the spine. And that's just an endoscopic picture of a tether in place in the thoracic spine. The lung is deflated to the right there, and then the ribs on the left side of that picture. So the goal of tethering is to harness the scoliosis patient's inherent spinal growth and redirect it to achieve correction rather than progression of the deformity. And I'll just say that's not a new concept. This is the international symbol for orthopedics. You know, a tree that's growing crooked and it's being tethered. If you look in the background, there's a stump, you know, a tree that looks like it's been chopped off. And I don't know, maybe that represents fusion, but here's the basic science behind progression of scoliosis and tethering. This is a vicious cycle where, you know, bone that is under too much compression, like on the inside of a scoliosis curve, grows less, and bone that has tension or less pressure on it will grow more. So whatever creates the scoliosis in the first place creates an asymmetric set of forces, too much on the inside of the curve, too little on the outside. And that creates asymmetric growth. You don't grow on the inside as much as the outside. And then you get a bigger curve. And then you have more of that asymmetry in forces and growth. And that's the vicious cycle. And that's why scoliosis probably progresses so much during a growth spurt. And the goal, the goal of tethering is really to reverse that, to straighten the spine so there's not as great an asymmetry in the forces, and with the tether really to compress on the outside of the curve so you can slow down that exuberant growth and encourage growth on the inside of the curve. Okay, so I'm going to take you through, I think it's about 10 questions that we asked as we started this, 20-something years ago, to try to take something again, from bench to bedside, really from an idea to something that would be reasonable to treat patients with. And we started asking the question, can we prove that this is a safe and effective treatment option? And in order to do that, we had to develop an animal model. We did that, developed a progressive scoliosis model in a goat. And we were able to show that we could correct curves with a staple modestly. Not very powerfully, but we showed an effect. And that set the stage for Randy Betts at the Philadelphia Shrine to utilize that same staple in a number of patients. And this is just an example of a patient with a progressive 38-degree curve with a lot of growth. That curve has close to 99% chance of getting worse. And the staple allowed slow correction to 30 and then 25 degrees. So a moderate correction of that deformity. Early on, we knew, because we did all the testing on the staple, that it wasn't an optimal device. So it's one piece, it's semi-rigid or rigid, it's made out of metal, shape memory metal, but it's rigid, and it doesn't really attach to bone very well. So what we developed was this anchor and loop ligament construct that we thought would better attach to the bone and would allow some flexibility and would allow us to get a better correction at the time of surgery. And the first question then was, well, which of these really is better? At that same time, and this is sort of early 2000s, there were a number of people getting interested in this who had their own implant systems that went from rigid to flexible. And we've always been on a very flexible end of the spectrum. These were what those implants looked like, very big staple plate type devices way over on the left, multiple shape memory staples next, and then maybe a cable by Newton. And we really had the most flexible idea, just hoping to preserve motion, function, the health of the discs, things like that. All of these were tested in different scenarios and showed some effect. So a straight spine creating a little bit of a curve by Wall, Betts showing some modest success in humans, and then Newton showing a cable creating a little deformity at a single level in a bovine model. We were the only group that was testing these devices in an actual progressive scoliosis. That was from, creating an animal model. And we were the only group that ever tested implants head to head, so one against another, which, you would do if you could. It's a good way to figure out if something's working and how well it's working. And what we were able to show, if you had a very large curve in the 70-something range, a staple did not stop that curve from getting bigger and bigger, up to 90 degrees, sometimes to 100. But a ligament tether could stop that progression and give you a little bit of correction. And this was a stiff scoliosis in a very large curve, so it didn't give you a huge amount of correction, but it at least showed that this was probably a better device than the staple. Larry Lenke, who has the classification system for scoliosis, was the first to implant a tether in a patient. And if you can see here, one of those middle pictures is a front view of screws and a tether, correcting that curve down to 25 degrees. And here's the progression over a 4-year period. Slow progression of that, slow correction of that curve from left to right down to about 6 degrees. The only problem with this is that was a very nice correction, beautiful proof of concept, but this child still had substantial growth and overcorrected. And I think Larry did about 3 of these patients. They all corrected and then overcorrected, and so the tether had to be removed. Nice proof of concept, but still needed a little honing. So which implant strategy is the most effective in correcting scoliosis in 3 dimensions? This was a study we did early on using CT scans to compare the staple and the anchor. It's a study that has a lot of data, but I'll just tell you that the staple, because it didn't control the scoliosis, didn't control the other planes of deformity, whereas the tether did a much better job of that in multiple planes. Which implant strategy demonstrates greater integrity over time? And by integrity, I mean, if you put an implant in a patient, you want it to stay where you put it. You want it to be well fixed and stable over time and not loosen. So if you put implants in and get a fusion, the fusion takes over and the implants aren't loaded or moved anymore. If you have a procedure where you're trying to preserve motion, it becomes harder because that implant is going to be loaded forever and has a chance of loosening. So again, we compared staple to anchor, and we found that almost half of the staples had loosened or slightly backed out. You can see at the apex of that stapled curve, a staple kind of trying to back out there a little bit. The anchors occasionally would drift. They'd change their angulation, but they did not seem to loosen. This is a coronal histology slice. I don't know if you can see my arrow, but these are the metal shoulders of the staple. The staple here comes across the disc, and you see all this fibrous tissue is really just loosening around the staple. And then on the other side, you see the anchor, a little easier to see the shape of that implant, but you can see this flowing bone going in and out of the implant, suggesting that it's well fixed. And this is even more dramatic. This is what's called a backscattered electron image. So here's a staple shoulder. This black is really a fibrous tissue halo. And then the bone is this gray sort of woven structure over here, way away from the staple. So that's a loose implant. If you look over here, you see bone intimate going into that little divot, coming over here, and you even see this beautiful blood vessel coming right up to the implant. This is a well-fixed tip of the anchor. So that anchor was very nicely fixed. We looked at the mechanics of that as well. If you put a staple in and try to pull it out at time 0 right away, it takes about 100 newtons of force to pull it out. As it loosens over about 12 to 16 weeks, now it takes only 86 newtons to pull it out. So it loosens and is weaker over time. If you look at the anchor, it's almost 500 newtons immediately to pull it out, and then over 600 as it grows into the bone. So nice that we had something that we could depend on to be well fixed over time. Which implant strategy optimizes vertebral growth modulation? So we did a study very early on and looked at the staple. We showed that the staple could decrease the angulation at the apex of a curve about 2 degrees. It's not very much. And alone, that was not statistically significant. But when you compared it to this increase in angulation without a staple, it was significant. So the staple provided some control of wedging at the apex of a curve. That is sort of a relative estimation of control of growth using an angular measurement. The absolute is using millimeter measurements. So we did another study where we looked at both of those, relative and absolute modulation of growth. And we asked the question, could we actually reverse this Hütter-Volkmann cycle? So you have to stick with me through this. These green arrows are what we want. We want to create compression on the outside of a curve to slow the growth on the outside of the curve. And the staple did a pretty good job of that. That's why I made these arrows green. You would like to be able to encourage growth on the inside of a curve, but we didn't do a very good job of that. These smaller red arrows mean that we created some compression over there, but it was less than we created on the outside. So we had some control of the curve, but not optimal. We did another study where we used a straight spine really to see if there was any chance at all that we could reverse this Hütter-Volkmann effect. And what I mean by that is, could we create compression on the side of the staple or the side of the tether so that we decrease growth, but could we also encourage growth on the other side, move it from whatever normal was to above normal? And that's the simple answer. No, we weren't able to do that. And our hypothesis was this. So the hypothesis is the staple is going to decrease growth on this side and increase growth on the other side. And the tether over here is just going to do that. The bigger green arrows mean it's just going to do a better job of it. And here's what we found is if we looked at the staple, and this is looking at the initial height of the T11 vertebra, this is what the growth did. So on the side of the staple, the growth was only 45% of normal. Okay, so we decreased it. That's good. For this growth to be encouraged beyond the normal level, this number would have to be above 100%. And it also got decreased, almost the same amount as this. So the staple almost slowed growth on both sides of the spine. The ligament did a better job. It decreased growth down to 24% of normal on the side of the ligament. And on the other side, didn't decrease it as much, but still decreased it. So there's nothing that's we've demonstrated so far that can increase the growth above 100% on that opposite side of the spine. And as you might expect, the angular changes from those two devices were substantially different. Okay. Are active and passive components important in these fusionless scoliosis implants? Well, what we mean by active is the initial correction of the curve, and then passive correction is what growth does over time. And this was an animal model where we created active correction. You know, we created a curve of about 33 degrees, and then growth added another 50% to that over time. And so we wanted to see if there was a substantial difference between staples and ligaments that are tensioned differently. And what we found is that staples didn't do a very good job at all of creating a curve or actively or passively correcting scoliosis. And if we submaximally tensioned a ligament, we got a decent amount of active change and we got a lot more deformity over time. And the thought there is if you can create a deformity, you can also correct it. And then this was a an even more significant construct, 3 staples here versus a maximally tensioned ligament. And you can see the more active deformity you create, the more deformity you create over time. Those radiographic differences, somehow that slide got erased, but basically the tether did better in all circumstances, and the staple just didn't do very well at creating deformity. Are there differences between static and dynamic loading? So a lot of orthopedic implants are static. They hold the spine in one position and don't move. Dynamic loading has a lot of attractiveness, and we'll show you here in a second how it actually is more physiologic and more effective. So here's that spectrum of implants we talked about before. You know, a rigid implant should be static and a flexible implant should be dynamic. Not always true, because a rigid implant can loosen and then the environment is no longer static. What we did to control the environment as much as possible is we utilized this rat tail model. Basically, the tail of a rat is a spine. It just doesn't have a lot of nerves in it, and it's not hidden in the body cavity, so it's a little easier to access and control forces. And so what we were able to do is create a model where we compared static and dynamic loading. And this is a fairly dramatic change in angulation at a single vertebra in just 3 weeks. So what we showed is that if you used dynamic modulation, so just 1 hertz, that's 1 load on the vertebra per second, over 3 weeks, we got 50% more wedging of the bone, or more control over the growth, more modulation of growth, versus less if we just statically loaded it. So dynamic loading is more like what a tether is going to give you, and a static load scenario is more like what a staple would do. And this is just an example of that angular change over a 3-week period. Okay, so remember how we talked about wanting to avoid adjacent segment problems with fusion? That's why we started investigating tether in the first place. So what we wanted to know is what were these fusionless procedures doing to the discs? And we had some, hang with me on this because this is complicated as I step into it, but this was a goat model early on where we showed healthy discs in the controls, but all of the discs, whether they just had a scoliosis or they got stapled, had degenerative changes in the discs. So what was causing the degenerative changes? Was it the scoliosis or was it the staples? We didn't really know. We did know that there were very different biomechanics of these devices. 3 staples is more rigid than 2, is more rigid than 1. And a flexible cable or a flexible tether is very flexible. The more flexible the device spanning a disc, the more the health of the disc will be preserved. And the more rigid you make a disc, the more you create degenerative changes. So we showed, and this green circle over here shows a loop ligament preserving almost 90 to 100% of all of your motion. So that was very encouraging. And then if you look over here, 3 staples, decreased some of the motion of the spine to 50% range. So we thought that if we compared staples to anchors, staples to tether or ligament tether, that we could show a difference in potential degeneration of the discs based on the implants. And we looked at 2 areas, not only the subadjacent discs, that's what's in the green arrow, but the discs that are actually under the implants. And we looked at just about everything you could possibly look at in a disc that has been written about or associated with degeneration. We even looked at the end plate, which is the part of the bone right next to the disc, because that's key to the health of the disc. And what we're able to show is that some of these things did change, with the implant. Importantly, there were no changes in any subadjacent discs. So all the discs next door were fine. Some of the discs under the implants had decreased cell density, increased apoptosis, that's a fancy word for cell death, and increased vascularity or decreased vascularity of the end plate. So all three of those things are somewhat associated with degenerative change. Now, the important thing is that the staples cause those with almost no scoliosis. So all of the degenerative changes we saw with the staple, which were mild, but were all due to the staple and not really due to the scoliosis. The tether created 50-degree curves. And so some of those degenerative changes probably were related to the scoliosis and not really just the implant. But so when we looked at the health of the discs, there were some changes in the discs under the implants with a staple or a tether. They were mild, but probably in the tethered group, a substantial portion of those changes was due to the deformity itself. Okay. This is the last sort of basic science question I'm going to ask, but it really almost gets in over our head, but it was an area of study that I was very interested in at one time, and actually think somebody could do a whole PhD on this if they were interested. But we were very interested in the underlying mechanism of vertebral growth modulation, really what's going on at the cellular level. So if you look on the left here, this is a normal growth plate in a rat tail vertebra. And you see these palisades of cells going from a resting zone, proliferating, and then going to this hypertrophy zone. They get big, they die, and they form bone. So this blue is cartilage, and this down here, a little lighter purple and pink, is more bone. And there are cellular mechanisms, there are molecular signals that cause all of these changes in bone. And what we were interested in, this is one of the angled vertebra from one of our studies in the rat tail. And we wanted to know what were the positive and negative molecular signals that were causing the growth plate to grow more on the outside of the curve and less on this side. And we weren't really able to answer this, but we were able to demonstrate that the two most important areas in the growth plate were the zone of proliferation. That's where resting cells then become active and proliferate. And then the zone of maturation, where cells get as big as they're going to get. And basically, the more cells you have dividing, and then the bigger they get, the more your bone's going to grow. The faster it's going to grow and the bigger it's going to get. And there are ways of quantifying the zone height, the number of proliferating cells, the zone height for maturation, and the final cell height. And we looked at a number of molecular signals that have all been implicated in growth in the growth plate. And this is pretty complex data, but we basically showed that static and dynamic demonstrated significant changes, most importantly in the final height of the chondrocyte. Like how big the cells got was the most important factor in our rat tail model. And importantly, sort of three molecular signaling proteins, aggrecan, collagen 2, and collagen 10, that all have to do with how big those cells get, showed differences, convex to concave and static to dynamic. So is there a potential down the road that we could figure out the molecular signaling in scoliosis and actually have a more elegant, non-orthopedic, non-mechanical solution? Yes. And this would take a lot more work, but it's an exciting area. So I know I've beaten you up a little bit, or maybe a lot, with that basic science, but it's important to understand that we just didn't think of something in the shower and then throw a rope in a patient's spine to try to correct their scoliosis. There was a lot of thought that went into doing our first patient. And now what I'm going to talk about is just the clinical side and hopefully get to that spina bifida patient. So who should be treated with fusionless scoliosis surgery? Well, early on, I wrote a chapter way back for the Academy of Orthopedics, and we thought that we had no idea if this tethering or even the stapling was going to work. So we thought very small curves should be treated. And what we found is that staples didn't really do a very good job. They could control some curves that were really pretty benign curves, but they didn't really do a very good job of more significant curves. And so this is a patient on the left that I wound up having to fuse because the staples didn't slow the progression down at all, compared to a patient on the right that we had very nice control of that deformity with a tether. This is really what the devices look like. You've seen them throughout this talk, but we did a study that we published in 2014 comparing these two devices. And basically, the staple in green didn't really control progression of the curve. So that green line going up just means the curve got bigger, and the tether did a pretty good job of controlling that. This was the first patient we ever did. We did this in March of 2010. This was the first successful patient ever treated with a tether. And we did curves that were slightly under 40 degrees. We showed nice initial correction of the curve. This is what the spine looks like right in the middle. That's the lung over on the right and the ribs over on the left. And that's what the tether looks like when you implant it into the spine. And that's just a thoracoscopic picture. Here's good control of that curve over the first 20 months, getting up to 2 years. And then here is control of that curve long-term. So 10 years. This girl has graduated from college. She has a nice job. She played college rugby. She's very happy. Her curves have changed slightly over the course of 10 years, but 25 degrees and less is a mild curve. And so we think this is a nice success. She certainly quality tested the cord by playing college rugby without rupture. So where are we today? Well, we've got a 10-year experience. We're working on publishing at this point. 62 patients, 43 of them have really good long-term follow-up. Curves were on average about 48 degrees and corrected about 54% down into the mild range. We think that's pretty good. We've treated patients from all over the country. The demographics are sort of this, age 14, sort of a modest Risser sign, curves close to 50 degrees, and a lot of different single and double curve patterns spanning most of the Lenke classification. This is kind of a busy slide, our ideal indications, but I think it's a really important slide, especially for this group, if we're talking about, the potential of this new technology for spina bifida. These are the things about the ideal indications that we think are the most important. Adolescent idiopathic scoliosis, we know a lot about, and the curves tend to be reasonably predictable. Curves 40 to 60 seem to be the best range. Under 40, we don't treat anymore. We had a couple overcorrections in that range. The maturity, if you go below Risser 0, so if you are Risser 0 and you have open triradiate cartilages, we consider that Risser -1. That's too much growth. So think about age 10 and younger, really sometimes is too much growth. It doesn't mean you can't consider a tether, it's just not ideal. And you'd like the curves to be at least 50% flexible. There's a lot of other things we take into account, but those are the big ones. So here's kind of a typical patient in the ideal range. Risser 0, getting to be pretty good sized patient. The curves are not small, but they're in that 40 to 60 range. and we got very nice correction of both curves. And if you scrutinize this, you might say, well, how come you didn't make everything perfectly straight? Well, not even fusion makes it perfectly straight. But if you get curves into the 25-degree range, you really aren't able to see the curves very much clinically. So just when you look at the patient, you don't see a big curve. So that's a pretty good result with the tether. Are there acceptable indications? Well, this is where spina bifida comes in. We treat patients with very subtle neurologic issues like a Chiari, a syrinx, a tethered cord, but spina bifida would probably be included in a static neuromuscular issue. There are some curve types that we've expanded to. A Lenke 2 curve pattern has an upper thoracic curve. You can't reach there with a tether. We've treated some curves over 60, actually quite a few. And then at the extremes of maturity. So risser negative 1, but also some people who are more mature. Here's an example of a completely mature patient with curves that are in the mid-40 range. This patient had a bleeding disorder and didn't really want a fusion. And we got a very nice correction with tether of both curves, and she's done beautifully long-term. When we looked at our outcomes, it wasn't perfect, but you have to understand this is our first 10 years, and this was us doing this before anybody else. So a learning curve, there were no other people to teach us when we started this, and we were able to definitively treat. That means use the tether to correct and control scoliosis in 91% of patients. We had to revise 9% of those. So half of them we had to replace the tether because it broke. Half of that 9%. And then half of that 9% we removed because the tether was causing overcorrection. The 9% that weren't definitively treated, so those were the ones that overcorrected too much, and we had to convert them to a fusion. So if you look at curve correction, people talk about 40 degrees is a threshold where we don't treat curves surgically below that for the most part. And above that, you're sort of in a surgical range. So you'd like to correct curves under 40. We probably get 82% under 40. But really, the further under that, the better. Almost 70%, we get to 35. Half, we get under 30. And probably a third down to a mild range. And I'll just tell you that, one of the reasons we don't get them all to 25 is that we treat curves that are very large sometimes. So they're just harder to get to a smaller number. Have we had complications? Sure. No catastrophic complications, but early tether rupture happened once because I over-tightened a set screw. I'll show you that case. Late tether rupture, we've had 8 of those, but only had to revise 2 of them. Overcorrection, we had 3 in our first 10 cases, and inadequate correction is really, I think, getting talked into treating a much larger curve that you can't really get to a good number. We've had a couple pulmonary effusions, but that really doesn't jeopardize the outcome of the tether, and that can be treated very effectively if it occurs. Importantly, with this new technology, this new procedure, we've avoided major medical and surgical complications. So really haven't had any. That's a good thing. This was that early tether rupture. We corrected 2 curves very nicely here. And the second day after surgery, she stood up and the entire lumbar curve came back. And what you can see over here is the tether ruptured on either side, right under the screw. So it pulled back on either side, and that's just because I over-tightened the set screw. It's my fault. The set screwdriver was just not calibrated perfectly, but we've never had that happen again. This is that same patient, her preoperative curves, and then after we did the correction, and she's done well for 5 years without an issue. Here's a late tether rupture, 2 pretty big curves, corrected very nicely. You can see a lot more correction of this thoracolumbar curve down to 3 degrees. That's because there's no ribs, so it's a more flexible part of the spine. And what you see over time is, these lower screws, which were parallel, are now splayed a little bit down here because the tether broke. And I actually don't think her spine looks too bad. She's got two curves that are well balanced, no pain. She's not interested in having anything done, so we're just watching at this point. And you can't see the tether on an x-ray, but you can see it on a CT scan. This is just a CT slice, and you can see a faint bit of it here, and then it sort of disappears, and that's consistent with a rupture. This is what an overcorrection looks like. You can see two very small curves on the left, correcting to almost zero. You feel really good about that when you don't know that that's going to overcorrect, but she had a decent amount of growth and went the other way. So we took out the tethers, and she balanced very nicely and didn't need any additional treatment, but it was a second surgery to get her there. This is another patient that really disappeared and refused to have the tethers out. When we finally took them out, she had this huge curve over here, and it took me 6 years to convince her to have a fusion. Very nice correction from the fusion, but this was sort of a social struggle to get her where she needed to be. If you look at three-dimensional correction of these curves, we do a pretty good job of correcting these in multiple planes. We've demonstrated that. I'm not going to beat you up with the data, but we not only correct the scoliosis, but we preserve the sagittal contours, so thoracic kyphosis and lumbar lordosis. We do a little bit to improve the rotation, but not a lot. And this is what kyphosis does. This is what lordosis does. And this is what axial rotation does. So we also improve spinal balance. I don't know if you can see the big orange arrow there on the left. The whole trunk is shifted way off to the left, and you can see the rib cage doesn't match the pelvis. And then post-op, we've eliminated that trunk shift and got the curve down to a mild range. So coronal balance, we can improve significantly. Sagittal balance is usually in a relatively normal range and is unchanged. And then, can we treat more mature patients? You know, you may be confused if I spent the whole time talking about growth modulation, and then I tell you we treat, you know, more mature patients who have no growth to modulate. But what we've learned is that this is such a powerful device at changing the shape of the spine that we can get very nice results in patients who are more mature. Now, we've only done that, I think, up to the age of 23 is our oldest, but we consider those sort of to be at the tail end of adolescence. I know that's a stretch, but, you know, really, if you look at the Risser sign, you may not be fully mature until age 25, but you're not probably growing after your mid to late teens, but you can still get a pretty good result in these patients. Because you don't have the growth, you don't get as good a result. So if you look here, we had immature patients that we corrected, you know, down to less than 10 degrees on average. Mature patients, slightly bigger curves, we probably cut their curves in half. Still a reasonable result in both groups. This was a paper I did out of, I didn't do the paper, but the anesthesia people did it out of our Dartmouth group, and they just wanted to know how well these people did compared to fusion. And the blood loss with a tether was 140 versus 750 with a fusion. The pain and opioid use was less after surgery. The surgery time was less, and they had 2 days less in the hospital. So very nice, you know, for a minimally invasive procedure, the numbers work out pretty nicely for it to be very patient friendly. Okay, I'm going to try to conclude here because I know I've gone on for a while. Where are we specifically today? Well, in the last 2 years, things have improved significantly because we got FDA approval and we have a new device, that is a little bit better for this specific indication. I came to MGH for children 2 years ago. We've been pretty busy, and we did our 100th tether this past week. We got a great team. This is just our surgical team. I'm not going to put up everybody's name, but we're developing a center of excellence, and it's really this is a team approach type of issue. This was the first case we did at MGH. It's really the first case in New England with this new FDA approved device. I did the first case in New England back in 2010. which happened to be the first successful case ever. But this was a nice milestone here at MGH. And that was a more mature patient, but got a curve from a very severe level to a mild curve. Here is the curve I showed you at the beginning. This was a girl that had a pretty modest curve in the 48 to 50 range, I think right before COVID. And the curve went shot up significantly during COVID, made us very nervous, but we still got it down to a pretty good number initially, and then got some subsequent improvement with growth over time. So both active and passive correction. We've done a number of double curves. We've even done some hybrids. This is somebody who has an upper thoracic curve. That's the 61-degree curve, which you can't get to with a tether. It's too high in the chest. There's no way to access it safely. That if you're going to address it, and at 61 degrees you're only going to be able to fuse it, but it doesn't mean you have to fuse the whole thing. So this is a combination or a hybrid where we preserved a lot of motion with the tether lower down, and really, I think, corrected both curves and balanced her spine quite nicely. Not every curve can be tethered, and not every curve should be, considered for tether. This is a 110-degree curve we treated last year with a wedge deformity. So this little wedge of bone over here on one side with no partner on the opposite side is called a hemivertebra, and really creates havoc. The spine is almost, curving back on itself, but some patients really do just need a fusion, and that's their best option. So back to this case where we started, is this an ideal case for tethering? Well, I'd say flat out no, but you really need to be more thorough in the discussion of the options for this particular patient and curve pattern. So because of the substantial amount of growth, you cannot leave this curve alone. The size of the curve and the other factors, you're not going to treat this curve in a brace or a cast. So you're in an operative range, and you could do growing rods, but growing rods, you may know, have probably 100% complication rate or more. So everybody's going to get a complication of some sort. Not devastating, but something. And you're going to potentially have multiple procedures. Even if you do a magic rod or whatever, you're going to have multiple procedures to grow the rods with the spine. And that's usually a delay tactic, a temporizing procedure with the end goal of fusing. So growing rods, Vector, magic rods could be an option for this, but you'd really have to span almost the entire spine. Would tether be a reasonable option? Well, I don't know that tether is going to be a definitive treatment for this, but the top curve was relatively flexible. The lower curve was pretty flexible. And after much discussion, we thought that a tether would at least allow you some correction and some control of this deformity, and you could allow additional growth. So vertical height, volumetric chest growth, all the things that are important about growth, you would allow. And so we did a tether. And this is what one of the early x-rays looked like. So the curve is up around 80. We got it maybe just under 70. And, some of that deformity is from, level above, and maybe a little adding from this curve below, but not a great number, but better than, it started out. And we got some control of the lower curve. I would point to some other features that I think are reasonable, is that we lifted the chest kind of out of the pelvis. So if you look at the rib cage here, it's now above the pelvis by an inch or two, maybe an inch, instead of, if you look here, now it's below the brim of the pelvis. So what does that do? That gives more room for the abdominal contents and improves space for the lungs above. And over time, and this hasn't been a huge amount of time, but maybe a year or so, we've gotten this one down to about 60 and have pretty good control down here. And again, look, I think the chest we're allowing growth. The depth of this curve looks substantially different than this. Story's not over, but I think we're potentially in a better spot than we were. And the modest goals would be that we are controlling the curve reasonably. We did it in a minimally invasive way, and we are allowing growth. And there may be a role for something additional down the road, but there's at least a reasonable argument that we've achieved something with this intervention. So that's, I think, our first and only spina bifida case, but more to come with that one. Okay, so that's all I have for today.
Can't unmute myself. Thank you so much. That was fascinating, and congratulations on the FDA approval of this device. I think, this is a really good illustration of why we in particular are so lucky to live where we do, with medical innovation and just centers of excellence in Boston. And this is really fascinating. I think when you and I spoke a while ago about this presentation, you were very careful to say this isn't necessarily going to be a fit for every spina bifida patient. So if you could maybe talk a little bit about, as parents are exploring options for their children with spina bifida, certainly this is another tool in your toolbox, but what are the questions that they should be asking, the considerations that maybe you look at in terms of whether or not this is the appropriate
Yeah, it's a great question. So we have a lot of patients that come to us that have heard about tethering and want to talk about, its, potential use, for their child. And some people, have a condition, a kyphosis or a spondylolisthesis or something that there is no application for the tether. It's not even, it doesn't even make sense. But there are a number of people that have heard about the impact of the tether, and what we try to do is stick to principles and basics and figure out, can this be applied to a wider group than just straightforward idiopathic scoliosis? And one of the things we try to do is we always start by discussing fusion versus tether, but then the ideal range for tether. And, we never want to be, disrespectful or mean to anybody about the ideal range, but the ideal range is ideal because you can get the curve into a really good zone. It's flexible. It's, it's going to grow some more, and it's really going to behave in a predictable way. The more you're outside of that range, you have to have something that makes it a good argument to consider tether. So if you think about a curve that creeps up above 60 degrees, you're going to have a flexible curve and some growth to make it reasonable to go after that bigger curve. If you have a curve that's 75 degrees and there's no growth and it's stiff, you're fooling yourself. You're going to do a tether. If you did a tether, you'd just be doing a fusion within 6 months to a year. There's an additional issue that, adolescent idiopathic scoliosis patients have bone that's, the vertebra is approaching the size of an adult vertebra, and it has good, thick cortex, a good thick cortex around it. So if you put a screw in it, it will hold the screw. Under 10 years of age, your vertebra, it's a spongy bone to begin with, but it's very soft and cartilaginous sometimes. If you go back to the age of 5, it's super soft. So I think some people have thought, well, if you can do this in a 12-year-old or a 14-year-old, well, you can just do it in a smaller person. It's just a little bit smaller, but it's not exactly just smaller. The bone is a lot softer. So when you go in, there's no good way doing bone density scans, quantitative CTs, whatever you do, there's no good way to tell how soft the bone is. And if the bone is too soft, you're going to be trying to correct the spine and just pushing the screw through butter. So that's something that is there in most patients under the age of 10, and closer to 10, the better. But it's a potential limitation that, if you're treating patients between the age of 5 and 10, can be a limiting factor. The other thing is, idiopathic scoliosis tends to follow a little bit more of a predictable course, how fast it progresses, how it behaves. And so when you tiptoe into other diagnoses that are more complex, you don't always know exactly how the curve is going to behave. And, with a fusion, there's less concern because you just took over all the behavior and made it a rigid, one structure. With a tether, you're working with the spine. You're relying on its behavior to benefit the patient. And so the better you can predict the behavior, I think the better you're going to do. So what I would, I've evaluated a number of patients with spina bifida, and the majority of them probably weren't great candidates. And sometimes that's just because the curve is too big, it's too stiff, and there's not enough growth. If somebody really has a curve that's more in that 40 to 60 range or slightly above, but there's other factors that are worth looking at, I don't have any problem, looking at this as a potential option for somebody. There are additional factors. If you have a kyphosis, a significant kyphosis, it's not a good idea to probably do a tether. So I think if you have a curve that's located appropriately, is in a reasonable range, has some features, flexibility and growth that allow you to maybe get it into a good zone, it may be worth considering a tether. It's hard for patients to actually know and families, if they have all the criteria, because that's not always tested at, every center. But we're happy to talk to people and, try to guide them. And I will add something that we haven't done yet, but we've thought through, where, in certain circumstances, you could potentially, utilize a growing rod initially to take a bigger curve into a much better range. And instead of transitioning, doing growing rod for 5 years or more and then transitioning to a fusion, you could potentially transition an initial growing rod, if you got the curve into a good range, to a tether.
That was going to be my follow-up question. Is it sort of fair to say that given this new option that, as children are growing into that sort of sweet spot in the 10 to 14, let's say, age range, that it's something, as you keep an eye on the development of the spine, that you could consider, and maybe there would be an option like what you just mentioned to get you to where the tethering might be a better fit into that adolescent time frame where it would have otherwise been too late or not appropriate.
Yeah, it's a great question. So if there are any surgeons on the call or in the meeting, they might be pulling their hair out saying like, oh my God, you're going to mix and match so many different things. It's going to be so confusing. I think, I'm not trying to make it more complicated. I actually think every single patient has, individual variables that need to be assessed. And all of this is incredibly individual. There's no way to say, oh, my friend had this, I should have that same thing. So you need an individual assessment. And what I like to do is really just stick to the basics. Like, what are we trying to achieve? What are the things that could get us there? And what's standing in our way? And you have to be really sober about what's standing in your way. Age, how mature the bone is, how mature the patient is, how big the curve is, where it is, how many curves, how flexible. All of these things start to really matter. So I think, you don't want to take something and say, oh, we did a bunch of tethers and they all failed. So now we're doing tethers with growing rods. That's not what I would be advocating for.
Right.
But there are some people, we've evaluated them. They don't have a role for a tether. They're too young, too small, but you could utilize a growing rod strategy to get them, through that early period. And you certainly, if they got older, could consider transitioning them to something that, was more definitive. Like a fusion is usually the definitive end to growing rod strategies, but maybe trade that out in certain circumstances for a tether.
We actually have a question in the chat. What are the complications for spina bifida, scoliosis, and kyphosis if no surgery has been done for a patient that's 32?
Yeah, so it depends on the size of the curves. So kyphosis sometimes can be tolerated up into the 80, 90 range, as long as it's not progressing. If a kyphosis gets above 100 degrees, it can sometimes really hunch you forward, cause some pain and some issues. Scoliosis is something that also, some people will tolerate. Curves above 50 tend to get bigger each year, about a degree, which, it's like watching the grass grow. You don't see a lot until you get a decade down the road or another decade. But, curves that get above 100 degrees, 110, 120, you can start to have lung problems. And sometimes even heart and lung problems if you get too much above 120. But if the curves are already above 100, kyphosis and scoliosis above 100, those are pretty big deformities that sometimes can cause some pain. They can cause positioning issues just because they're big deformities, and they can start to impact heart and lungs. If they're much smaller than that, at 32 years of age, you might be managing them very well, but they still might progress over time, and it wouldn't be unreasonable to sort of talk to somebody about options.
We've talked a lot today about transitioning from pediatric to adult care, and this is just another area where it's so important for the individuals to really learn about this and about their options, and find providers that can give them that informed opinion and let them know what their options are.
I think it's something we struggle with too. So I was very lucky in my training to see, to treat a lot of pediatric patients with spinal deformity and treat adults in every decade of life, because they're all connected. And, some people have to choose what they treat. Some people just treat adults, some people just treat children. But I think it's hard if you only treat children to see or to actually have a palpable understanding of what happens to adults. But I do think that, improvements in treating very complex pediatric conditions is great, but it has now led to this no man's land where you have, young adults in their 20s and 30s who are wondering, well, who's going to treat me? Because everyone who treats this type of thing only treats kids.
Exactly.
So I do think that is a struggle, and we work very hard to get, I think I follow people forever, but it is hard for people to get, Boston Children's is awesome for treating all these things, but I would probably guess that they don't have a lot of 32-year-olds that are, have an easy time getting into their clinics.
Yeah.
Or even to our clinics. I mean, it's a hard situation.
Well, and I know, work is being done from our national association, and I know with partnership in the hospitals in the Boston area and across the country to try to improve the transition process and increase access to adult care for people. But we definitely, still have a long way to go, and hope that that's something that we can continue to work together, and support all of you in that work, so that, you know, it's just surprising that in the Boston area, I mean, arguably the hub of epicenter of medical care in the world, right? It's still so difficult to find medical providers as an adult with spina bifida. And so, you know, that's why doing things like this is so important, and for us to be able to give information and access to you all, so that our members just can be more informed about their own medical care as they age. So, and this is apparently a rugby tested procedure. That really threw me. Kudos to both of you.
Well, so, you know, there's a reason to put that in there. So the tether rupture rate at some places has been as high as 40 or 50%. So people say, oh, it's going to break in everybody. And so there's a specific reason that I, for a 10-year follow-up patient, say, well, it doesn't necessarily break in everybody.
Yeah, she didn't break it. So that's pretty remarkable. I think that we covered the questions that were in the chat and the Q&A feature, and I know that we've gone over time and kept you late, but I can't tell you enough how much we appreciate your time. This was an excellent presentation, and we will absolutely be sending the recordings out to everybody from today's presentations, and you know, any follow-up questions, people can just email us and we'll get back to them. Thank you again, Dr. Braun. We really, really greatly appreciate it.
Sorry for the technical glitch at the beginning.
You know, we can't fix everything. So
well, at least we got to it. So
there, absolutely. So thank you everybody for your patience.
All right. Thanks again.
Thank you so much. And so this is the end of our very first ever virtual conference. Thank you to everybody that participated, obviously to our providers and our board of directors for making this possible, and especially to our sponsors, Coloplast, Boston Children's Hospital Neurosurgery Foundation, Hollister, Mass General Hospital for Children, Mobility Works, Permobile, and National Seating and Mobility. Thank you again for participating. We will get the recordings out to you next week, and we hope you enjoy the rest of this beautiful weekend. Thanks so much.
Thanks again.